and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS learning that you can fit into your busy life. I'm Dawn Liz Powell, medical editor at MIMS Learning. Today I will be speaking to Dr Patrick Holmes about type 3C diabetes, specifically about when a GP should suspect this type of diabetes. Patrick, welcome to the podcast. Please, can you tell us a bit about yourself?
Yes, I'm an old GP these days. I qualified in the last century and joined my practice in 1998. So during my career, I've developed an interest in diabetes and worked both in primary care and secondary care at the interface when it comes to diabetes.
Thanks for that. Okay, so what is type 3C diabetes and roughly how prevalent is it?
So type 3C diabetes or pancreatic diabetes, that can often be easier for people. It's difficult to be absolutely certain the prevalence, but maybe between 10 and up to 20% of people with type 2 diabetes may indeed have this type 3C diabetes.
Okay, so you're talking about pancreatic diabetes. So obviously there's sort of a link to the pancreas, and that type 3C diabetes can occur because of damage to the pancreas. Who is most at risk of having pancreatic damage and thus at increased risk of type 3C diabetes?
Okay, so I think most common is probably actually people who've had chronic pancreatitis, often not diagnosed, but people with history of excessive alcohol. Of course, people who've had pancreatic surgery are at high risk if you've got those on your list, people who've had Whipples. And then there are other conditions like cystic fibrosis or even hemochromatosis, which can present with this pancreatic diabetes where they lose pancreatic tissue and therefore the hormone insulin, as well as other functions of the pancreas, becomes deficient and therefore the sugars rise.
Just for clarity, what do we consider alcohol misuse these days? Because we sort of have the stereotype of someone who's perhaps an alcoholic, but you can get a lot of people who do drink a lot and they're sort of functioning. They're not getting drunk, but they are drinking a lot all the time.
I think you're absolutely right. I think it's really difficult. I think alcohol misuse is when it's causing harm to the individual, and that will happen to a whole host of people. A lot of it's hidden, so this may not be on their record. So yes, people with an alcohol dependence syndrome would definitely tick that box, but in truth there are a lot of people out there who are drinking too much and it may be adversely affecting their health. And there's a little bit of genetics on here. There are some people who are more prone to get hypertriglyceridemia when they drink too much, and that in turn triggers the pancreatitis, and over time that can lead on to a chronic pancreatitis. And of course a lot of people would have perhaps put this alcohol excess, just say, oh, it affected my tummy, they got a bit of bellyache, and didn't equate that to actually it being a form of pancreatic damage at the time.
For the GP, what are the red flags that someone's got this type 3C diabetes?
As I said, it can be often missed in my experience. So the people one needs to think about if they've already got a diagnosis of diabetes are those people who aren't responding to the traditional oral therapies, those people who rapidly progress onto insulin, let's say in the first 1 to 3 years. If they don't look like a typical person with, let's say, type 2 diabetes, so they've got a lower BMI, maybe they're losing weight. So these are triggers that would be concerned. Obviously, I've already mentioned the past history of if they've had pancreatic disease or surgery. Then there are other clinical features. So when we're talking about the pancreas, of course, the pancreas has an endocrine function, so producing hormones, but it also has an exocrine. It produces the enzymes involved in digestion. So if people have pancreatic insufficiency, they would also have exocrine pancreatic insufficiency, and that could lead on to abdominal symptoms, steatorrhea, foul smelling stools, and as I say, that malabsorption, which can lead on to that weight loss.
We've just done a case study on MIMS Learning about latent autoimmune diabetes, so sort of type 1 diabetes presenting later, really. I think excessive weight loss can be a sign of that type of diabetes. Is there a way of distinguishing between type 3C and latent?
That's a very good question. And of course, the underlying pathology being different, one was autoimmune and the other one is caused by pancreatic damage, but the link there is they have low insulin levels. So they can look very similar. I suppose those exocrine function abnormalities are probably the main feature. So if they're getting a lot of GI symptoms, and you might need to directly question it, because if it's been there a long time, people may have just put this down as normal, or indeed, often people are on metformin and they'll blame gastrointestinal symptoms on their metformin or other medications that they're taking. So I suppose it's being aware of that possibility in that situation where people are not responding to oral therapies or requiring insulin. And the tests are different in LADA, and for that matter, as I'm suggesting, in terms of pancreatic diabetes, type 3C diabetes.
That does make me think about the different types of diabetes and how a GP should distinguish between them. What are your tips for the differential diagnosis?
Ask for help. Diabetes is complicated because differentiating between you highlighted LADA, for example, but type 1 diabetes, type 3C, type 2, in people under the age of 35, 40, monogenic diabetes, it is complicated. And GPs obviously play a pivotal role in making that diagnosis. It's a really tough call sometimes. So we've got type 1 diabetes, which doesn't always follow the same path. Remember, the majority of type 1 diabetes is actually made in adulthood because people live so long. And type 2 diabetes, which is by far the most prevalent. Type 3C, pancreatic diabetes, in younger people, particularly with very strong family history, maybe having monogenic diabetes. So I suppose it's being aware that as a GP, you have that pivotal role in making a diagnosis. Always think type 1 diabetes if people have got strong osmotic symptoms and are losing weight. If they're young, under the age of 35, make sure you've got that good family history and use things like Exeter tools to help with the diagnosis, and keep an eye on them. Once they're diagnosed, it may be that certain types of diabetes, both certain types of latent autoimmune type 1 diabetes and type 3C diabetes, just become more obvious over time that people are not responding to the usual type 2 diabetes treatments. And I can't reiterate enough, if you think they've got type 1 diabetes, phone a friend.
Okay, so we're talking about identifying type 3C diabetes in a person with an existing diagnosis of diabetes. But what about someone with suspected diabetes?
You raise a really important point, because one of the causes of pancreatic diabetes could be carcinoma of the pancreas. So this would be someone typically over the age of 50. It can happen at a younger age, but typically this is a condition as people get older. But these are people with new onset diabetes, usually associated with weight loss, and may have additional symptoms associated with pancreatic cancer, such as abdominal pain, back pain. So I think any new diagnosis, particularly in the context of weight loss over the age of 50, I think one needs to be a little bit careful that we're not labeling them as having, let's say, type 2 diabetes, because obviously we need to be acting very promptly in these people.
You were mentioning before about the foul smelling stool. So presumably a stool sample might be quite a good way to test for type 3C diabetes.
Absolutely. It's probably one of the key tests. So it's fecal elastase. So elastase is one of the enzymes produced by the pancreas and can be measured in the stool. So if they've got low levels of fecal elastase, that's pointing to the diagnosis and is a very simple and easy and relatively cheap test to do.
If type 3C diabetes is diagnosed, is that person then referred to a specialist?
It will very much depend on the context, but I think if this was unknown pancreatic disease, I think it's useful to involve or at least get at some advice and guidance. If there's any concern, of course, of pancreatic cancer, then that would require urgent referral. I think for most GPs, they're probably going to be referring on, because although they can initiate pancreatic enzyme replacement therapy, it's not something we commonly initiate in primary care. So specialist input is useful, although again, advice and guidance will be helpful. In terms of the glycemic management, they're likely to require insulin. And again, that will depend on the expertise of the primary care team, but often may require specialist input. They can be quite challenging to manage because, as I said, they've got low levels of insulin. So if you don't get that right, they're more prone to have hypoglycemia because they're relatively insulin sensitive compared to most people with type 2 diabetes, for example.
So just you were mentioning PERT, pancreatic enzyme replacement therapy. I mean, that's had quite a lot of shortages recently, hasn't it? How have you been managing that?
Yeah, it's been a pain, I think, is the truth. I've got more people on this because I've perhaps been more aware of it and manage a lot of people with diabetes. So it has been a real pain. I think that for me, the key person has been our pharmacists, particularly actually our local community pharmacist, who's done very well. As long as I fill out the prescriptions as he tells me, my patients get treatment and can access it. At certain times in the past, we had to restrict it. So it was really, we're restricting it to those people who are getting weight loss or really bad symptoms. At the moment, it's fine, but in truth, I'm just watching the duck on the water. I think the pharmacist's little legs are going underneath the water to navigate this. But find a pharmacist who can look after it. And if you're a practitioner with patients going to numerous pharmacies, I think if you identify one or two which are particularly helpful at this, I would just signpost your patients to that pharmacist because it is a lot of work at the moment. We're used to shortages. How we navigate it is particularly challenging with pancreatic enzyme replacement therapy.
Okay, well, just to give a quick plug to our sister site, MIMS. MIMS does have a drug shortages tracker, which is regularly updated, and then that does give possible alternatives. Moving on, you were just talking about weight loss there, but I was just made me think about GLP-1 agonists. I know there can be this issue that people are on these drugs, perhaps without a good indication for these drugs, and they're on them privately, and they could be losing weight. Is that something you need to be considering? Is that they're losing weight because they're on a GLP-1 agonist and they haven't told you?
We know, certainly I know that one of the popular weight loss is a GLP-1, GIP agent. 90% of prescriptions are private rather than on the NHS. So a lot of people are accessing these. So I think it's a fair question. Obviously, people, for all good reasons, may be trying to lose weight and using these treatments. That's, I think, a consideration in people who are losing weight. I think now we should be probably proactively asking for that. There's a separate question, really, I suppose, is it a good thing to use those sorts of agents in people with pancreatic disease? And I don't think we really know the answer to that. We know these GLP-1 and GIP, at least in certain situations, could potentially increase the risk of pancreatitis. But when you actually look at the real world evidence, it doesn't appear that they do, because obviously losing weight actually reduces the risk of pancreatitis. So obesity being a key driver. So there's a bit of a balancing act probably going on in the real world. But certainly if people are thinking about using these sorts of agents for people with type 3C diabetes, I would definitely run it via a specialist, because as I say, really this is an insulin secretion issue. So that needs to be corrected before we go rushing off to using these agents. But individual cases need to be obviously judged on their individual merits.
So now going back to type 3C diabetes, you were mentioning there about pancreatic cancer can increase your risk of type 3C diabetes, but is it can be the other way around as well, that type 3C diabetes can be a risk factor for pancreatic cancer or marker for pancreatic cancer?
Yeah, I mean, obviously anything which causes, so if people have a history of chronic pancreatitis, there's a slight increased risk of that transforming into carcinoma of the pancreas. I mean, like any chronic inflammatory state, it can lead on to neoplastic transformation. So I think that's a consideration. The biggest concern, I think, is just capturing those pancreatic cancers early. I've already given you the key features in terms of being over the age of 50, unexplained abdominal back pain, and a history of weight loss with new onset diabetes. There are simple tests. I mean, you should be referring probably under a 2-week rule, but I would personally, I do something like a CA19-9, which will help pick up some. And in these people, I've got a high suspicion. I'm already at the same time as that referral to the specialist under the 2-week rule, I'm organising a triple phase CT scan of the pancreas.
In that, it would now be an urgent referral under the new.
Yeah, you're right. It's an urgent referral rather than 2-week wait. Locally, we still use the term just to confuse between the so-called urgent referrals, which seem to still take months.
I suppose it's more about communicating that to the patient, making sure that.
Absolutely, yeah. No, I mean, we need to obviously communicate quite clearly why we're referring, and also make sure that they tell us if things aren't working, because sadly, things don't always work in complex health systems. So safety netting is obviously vital in this sort of scenario.
Okay, and just to give us another plug for this time for MIMS Learning, we are running a year-long campaign on early cancer diagnosis, which is available on our website. So in the podcast notes, there will be a link to our campaign page. Do you have any take-home messages for GPs?
My take-home would be type 3C diabetes is a real thing. The prevalence is uncertain, 5, 10%, in certain cohorts even higher. So we need to be aware of it, particularly those people who don't just seem to be fitting either in the way they look, in terms of BMI, their response to treatment. Always remember to try to take a decent history, including alcohol and past surgical history, before you're making a firm diagnosis of type 2 diabetes. And the final take home is we have time in primary care often. So keep that awareness and that diagnostic uncertainty, at least in your own head, for some time whilst you're seeing how people respond to treatments.
Thank you so much for speaking with me today, and thank you to our listeners for joining us. Don't forget that you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. I've been Dawn Liz Powell, speaking to Dr. Patrick Holmes, and this episode was produced by Jude Owen. Look out for our next episode where the MIMS Learning editorial team will bring more highlights from one of the comprehensive CPD modules that we have on our website.